is Maddie. She's our 4-year female neutered Labrador that had was out for a walk, and then about half an hour later when she got home, she had an acute onset seizure activity. She had about 3 or 4 seizures within about a half an hour time period, lasting about a minute or two, and then she then went into status epilepticus when she arrived at her practice. So this is a video from her owner of her seizure activity. She had some other videos as well that I haven't got, but where she was hypersalivating, and a few that she would urinate and defecate. And like I say, quite a sudden onset of seizure activity following her walk. So this is a relatively good example of a dog coming to you with status epilepticus. And again, from those consensus statements, we try to define it as a seizure lasting for more than 5 minutes, or 2 or more discrete seizures where there's an incomplete recovery of consciousness in between. So that's the definition that we now use for dogs or cats in status epilepticus. And again, given her seizure activity and everything else that we know about her, we would certainly localize her to the forebrain if we are convinced that she's having seizure activity. And then in terms of the most likely differential diagnosis, this was a perfectly normal dog without any concerns about seizure activity beforehand. So I think a brain tumor is unlikely, particularly given how severe she progressed with her seizure activity. That also makes idiopathic epilepsy unlikely. It'd be unusual for a dog with idiopathic epilepsy to present in status. Normally they might have the odd 1 or 2 seizures, but to be that severe, it would be unusual. Again, meningoencephalitis is a bit too sudden. Normally those dogs are a bit abnormal for a few days before, maybe showing neurological signs before, but I guess it's possible. But for me, the one thing that I would consider with Maddie, given her recent walk and being outside, and the fact that she has such an aggressive onset of seizure activity, would be an intoxication. And so in terms of what you would do or what you should do for dogs arriving in status to your practice, I've sort of tried to provide you with this little flow chart, which you should have on your notes as well. So the main thing obviously is always try not to panic. Obviously, often the owners, when they bring these dogs in, are very traumatized, and often the support staff in practices are as well. The first thing that you can do would be to give these dogs a rectal diazepam and give them a decent dose. Do a 1 milligram per kilo dose rectally straight off to see if you can get them out of that seizure as quickly as possible. If you manage to achieve that, then the best thing you can do is then to place an IV, and from that IV, try and get some blood just to run a basic analysis, just to check the electrolytes and the basic PCV and total protein. And then I'd always start those dogs on fluids because they're often dehydrated, and if needed, supplement them with oxygen. And then depending on what happens next, depends on what you have to do. So if that dog continues to have seizures or continues to be in status, then you can certainly repeat the diazepam. Hopefully now you have an IV in, so you can do either half or 1 mg per kg intravenously. And if they have more than 1 or 2 seizures whilst you got the IV in, it's certainly worth considering to start phenobarbital. In terms of how to start pheno, again, this is something that varies between people. When we load a dog with phenobarbital, we often think about loading between 15 and 20 milligrams per kilo within a 24-hour period. If you gave a dog a one-off dose of 15 or 18 milligrams per kilo of phenobarbital, it's very likely you'll stop them seizuring, but it's also very likely you'll send them into quite a obtunded, stuporous, or even comatose state. So giving them such a hefty dose as a one-off treatment will probably work to stop their seizure activity, but it will make them so inappropriate in terms of the mentation, it'll be difficult to do much more with them from a neurological point of view. So what I tend to do is, if they're still seizuring, is to start them on phenobarbital at a dose of 3 milligrams per kilo IV. And then if they continue to have seizures, I just keep topping them up by 3 milligrams per kilo every time they have a seizure, up until the point of having a total of 15 to 20 milligrams. And that way, it means that you don't have to use all the phenobarbital straight off, so that you can try and get the balance between having a relatively normal mentation but controlling seizure activity. But it also allows you to see if there's anything else going on with that patient from a neurological point of view. If despite loading with phenobarbital, or despite a decent dose of phenobarbital, they're still seizuring, then I would certainly add in levetiracetam. And as I said before, I would start off an initial dose of 40 to 60 milligrams per kilo intravenously, and then follow it up with 20 milligrams per kilo every 8 hours, and see if that's enough to stop them seizuring. If it isn't, then you start to add in your CRIs. And for that, I'd either in midazolam or propofol CRI, or dexmedetomidine and or ketamine. So you can just keep on adding those in as and when you need to. It'd be unusual to get to this sort of point. I know you sometimes do, but most dogs will respond to the pheno diazepam and levetiracetam. If you're needing the midazolam or propofol, then obviously it's quite serious, and I'd be worried that that dog has an intoxication, even more so if that's the level of seizure activity.